I'm Kotil W. Ramahan. I'm the director of the Multiple Sclerosis Center at the University of Miami in Miami, Florida. As you know, the mainstay of treatment for multiple sclerosis is modifying the immune system in a manner that allows us to reduce the number of exacerbations that occur in a given patient. We have very clear evidence to suggest that it's really abnormalities in the immune system that leads to attacks that occur in the patient. And just about every treatment that we have developed for multiple sclerosis relapses center around modifying the immune system in a manner that allows the cells not to go to the brain to cause the injury. So a number of treatments were developed, and Gilenya is a unique drug in that this is the first of its kind. And the way this drug works is by modifying the signals that the lymphocytes receive. These are the cells in the immune system that go to the brain and cause the injury. If we can modify the signals that these cells receive so they do not have the opportunity to migrate to the brain, then the attacks that occur in multiple sclerosis can be prevented. And that's the basis for trying the drug. And this was actually first tested in patients with transplantation. And as an adjunct to cyclosporin, it worked. And that's what led to the trials in multiple sclerosis, where after an initial phase 2 trial, which showed promise, the trial compared this to both placebo as well as to interferon injections. And in both the trials, the drug turned out to be superior to both placebo as well as to interferon in reducing the number of relapses that occur in these patients. Basically, the relapse rate reduction was in the order of about 55%, and this was significantly better than the 33% that we are accustomed to seeing with the first-line drugs that we use today for treatment of multiple sclerosis. Tysabri reduces exacerbations by about 65, almost 70%, and it is very difficult to compare across trials because the populations are different. There has never been a trial that has compared head-to-head Gilenya with Tysabri, and if you look at the placebo arms of the two clinical trials, the exacerbation rate in Tysabri was 0.7. The exacerbation rate in Gilenya was 0.4. And of course, the drug turned out to be superior to that. Now, the fact that the exacerbation rates in the placebo arms were different in the two studies make it very difficult to compare the two trials across one another. I don't know whether the lower number of exacerbation rate in the placebo arm is a favorable thing or an unfavorable thing for a drug, but we always worry whenever you do a clinical trial that the placebo arm will not show the kind of exacerbations that we predict, because it's much easier to show an effect of a drug when the placebo arm is very active. So considering that the placebo arm was much more active in Tysabri, one would have to assume that if we were to have a similar population in Gilenya, the drug would be probably just as effective as Tysabri. So until and unless one does a clinical trial comparing Tysabri with Gilenya, we really are not going to get an answer as to whether Gilenya is as good or better than Tysabri. No, we have not. In fact, the safety profile to date has been actually quite good. There has been concerns about infections. There were more cases of herpes zoster that occurred in patients that received Gilenya compared to placebo or interferon. And there were 2 deaths that occurred, and one was due to a primary varicella infection, and the other one was due to herpes encephalitis. So we are a bit concerned about herpes infections and how that would affect a patient when the patient is on Gilenya. But this is something that we need to monitor and keep a careful lookout as we go into the phase 4 after release part of the drug. And that's why there is a REMS program to monitor these patients to see how well they're doing. We have to remember that when Tysabri was released, there was no cases of PML known, and it is only after it went into the market that patients with PML became apparent. And We don't have quite that same record with Gilenya at this point. The drug has just gone into marketing. At this point, it's only been a month or two since the drug has become available. So the next couple of years is going to be telling in terms of what we are going to find in terms of complications related to infections, in relation to malignancy, and so on and so forth. So the REMS program, which is basically the risk evaluation management strategy, is going to be extremely important whenever we use drugs like Gilenya, which are very, very potent agents. But we are optimistically hopeful that this drug will turn out to be what it turned out to be in the phase 3 trials, meaning that it's relatively safe and extremely effective. The cost of the drug is $44,000 a year. It's probably the most expensive drug on the market for treatment of multiple sclerosis. Now, there's no question about it. This is a very expensive drug, and when you compare it to the next most expensive drug, it's Tysabri, and the cost of Tysabri is in the $30,000 range, and the cost of interferons are in the $20,000 range. So this drug is almost twice as expensive as the first-line drugs that we use now. But one has to keep in mind that when you have a patient on Tysabri, that initial cost of the drug is not the end of the story. The drug has to be administered IV. It has to be administered monthly. So there is an annual cost that is accrued in addition to the cost of the drug, and that has to be pretty much added to the cost of the drug when one considers the apples to apples comparison, so to speak. And I think when you do that, when you compare the cost of Tysabri to the monthly cost of administration, the annual cost of Tysabri will probably come pretty close to what we would spend with Gilenya. Now, how do you justify the cost of the drug? There is a lot of research and development that goes into the development of these drugs. As you know, the phase 3 trial for transplant, even though it was favorable, was not pursued as an indication for transplant patients. There's a lot of money that was spent for that by the same company. The drug has then turned out to be much more effective, much more favorable in the MS population. So I have no idea in terms of the total cost that has gone into developing a drug like this, but it is an international effort, thousands of patients that have been involved in various countries. I suspect that all of these will go into the cost that will go into the marketing of the drug. So it is a very expensive drug, but probably not any more expensive than Tysabri when you add all the cost to the MRI monitoring in addition to the IV administration and all the antibody levels and all that you get with the drug. The drug is approved as a frontline drug and will probably be used as a frontline drug in those patients who are shy of using injections, because when we present options to patients, we will be giving them the options of the injectables together with Gilenya, and so it will be offered as a choice. And for those patients who choose the drug, they will enter into the drugs with the full understanding that this is a drug where we only have about 4 years worth of data, and that long-term safety information is yet to be defined. And so then the patient has to make up the mind whether they are willing to take the known safety of the first-line drugs versus the unknown factors associated with the use of Gilenya. But if the patient is willing to take the chance and would prefer to be on an oral agent, I think it'll be perfectly reasonable to use Gilenya as a first-line drug.